Well, welcome. This is Optometric Education Consultants. You're in the right place. This is OCT and OCT Angiography in glaucoma. And it's my great privilege and pleasure to introduce my colleague, my friend, and my business partner in Optometric Education Consultants, Dr. Greg Caldwell, who is a graduate of the Pennsylvania College of Optometry, where he also had done a residency in primary care and ocular disease. He has held many positions in organized optometry. I think probably the most significant, he was 3 years an AOA trustee, past president of the Pennsylvania Optometric Association. I know he is involved in the political action committee and is a disease consultant in a medical optometric practice. Greg has lectured all over the world, certainly all over the nation, on a number of topics in ocular disease. I know he has a special interest and passion in OCT and OCT angiography. So with that, it's my great pleasure to introduce and bring on Dr. Greg Caldwell to talk about OCT and OCT angiography in glaucoma. Greg, take it away, please.
Thanks, Joe, and thanks for the kind introduction there. And that is true. I truly enjoy teaching colleagues about OCT and especially OCT angiography, because as of now, it's almost impossible for me to really practice without angiography, especially within the diabetes arena, because diabetes is a capillary disease. Macular degeneration, when it's turning wet, picking up those early membranes. And we're going to see tonight, it kind of touches really in glaucoma. When's the last time we really did a fluorescein angiography for glaucoma, but then using the radial peripapillary capillaries and the capillaries around the macula where the GCC is to use another measurement and another structural measurement in glaucoma. So before we get started, we always got to do disclosures here, and the content of this activity was prepared independently by me. It wasn't developed by any company out there and asked me to present it. You can see I've lectured from Alcon, Allergan down through OptiView, advisory boards, Allergan, Sun, down through Dompe there. I do sit as the PA medical director for Involve, and I sit on their credentialing committee and their special unit investigation. It's a paid position, and it's an honorarium position. I guess I should say not paid, but an honorarium position. It's a managed Medicaid for Pennsylvania. I do sit as the chairman of the Advisory Council for Diabetes for Healthcare Registry. It's more of an outcome rather than MIPS. I have no financial or proprietary interest in any companies or products or service mentioned in this presentation. And really most important is the format of this course is presented without commercial bias and does not claim any superiority of any commercial products. So with that being said, I have an OptiView, and I'm going to try and teach concepts tonight that go across all OCTs. There are a few proprietary things, and I'll point those out along the way that OptiView has, and maybe some other OCTs don't. And Joe mentioned about half owner of Optometric Education Consultants. With that said, everyone wants to know the financial disclosures. How about my financial obligations? Here I am with my son, my wife, and you can see here that we are Disney people. So with those financial disclosures, go my financial obligations. And Joe, right off the bat, we have a polling question here. I'm just kind of curious, the audience tonight in their office, do they have OCT, OCT angiography, both? Or do we have no OCT technology? So just curious here. OCT only, OCT and OCT angiography, and no OCT technology.
All right, we had a big burst of activity.
That's a pretty good swath right there. I think we're good, and it's pretty much when we do. I'm still doing live lectures. I was in Texas a few weeks ago, did an OCT talk, and that was pretty much what we saw here. Is what we're sharing is majority of the people had OCT technology, and then of those, a small percentage had the angiography, and again, another small percentage had no OCT technology. So when it comes to OCT and in glaucoma, I go to a lot of lectures, sit through a lot of lectures, and we always talk about ganglion cell and nerve fiber layer and progression analysis. I think we do lose a little bit of the capability of using OCT for the anterior segment in glaucoma. So I just kind of wanted to touch on that tonight. And a lot of times when I want to take my pachymetry readings, I'll do both in the practice. I'll use my OCT technology, and you can see here that we kind of get a central thickness, and and then there's a bunch of pizza pie measurements going around here, and the little blue dot is the center, is actually the thinnest part of the cornea. So you can go with central cornea thickness. You can then take a quick look and see what the minimum thickness is. Like right here, it says minimum 569, and minimum over here is 575 in the left, and that would be over here in this left cornea. So you can go 586, using the ocular hypertensive treatment study numbers that were out there, 555 and 588. So I do like using OCT pachymetry. It's just more accurate over ultrasound. And it was actually Dr. Salka who you and I think your wife Jo did a small study using ultrasound and pachymetry, finding that the OCT was going to be a little bit thinner because it's always hard to get perpendicular on that cornea. Is that how that all kind of shook out?
Yeah, that was something that my wife did. I helped with that, and what we found was ultrasound pachymetry was almost always uniformly a little bit thinner, and it was freakishly reproducible, whereas ultrasound pachymetry had a greater standard deviation where it wasn't quite as reproducible. And
so,
as you said, that's because it's hard with your hand in free space to become perfectly orthogonal to that cornea, where it's much easier with the OCT.
So, I think I have a couple images here. So going back to this slide here, you're able to find the thinnest part. You're able to get the central cornea thickness. When you're doing ultrasound, your hands in free space. Down here is another way of doing it through a topography, what's called optical pachymetry. But you can see here that you're actually able to see the epithelium, some of the tear film, endothelium here, able to get truly perpendicular, where if you're trying to get this ultrasonic probe perfectly perpendicular, just imagine this line right here, just off just a degree or two. It's going to cut a little bit longer, and you're going to get a little bit thicker of a pachymetry. So I truly like using my OCT to get that true cornea measurement out there. And we're going to talk about central cornea thickness, and actually going to talk about it right here. So we have polling question number 2, Joe, if you'll launch it. We have two 55-year-old men. One has right here, as you can see, a 500 micron cornea with a 21 millimeter mercury with Goldman, and the other one has a 600 cornea and 21 millimeters of mercury. What's that true IOP? The 500, is it 18? Is it 21, 24? You just don't know. And the one with a little bit thicker, you're measuring 21. Is that the one that's 18, or is it 21, 24, or you just don't know?
All right, we're getting pretty close, so I think we're going to call it right here.
Yeah,
I'm going to end the
good.
polling, and we're going to show the results.
Yeah, so This still goes back to why I like talking about, central cornea thickness and measuring it. 500 micron cornea, 21 millimeters of mercury, we would assume that that cornea is, thin, and it, we had a kind of, when we cranked up there is, maybe we didn't, because it's thin, it indented a little bit easier, so that true as the majority of the docs here put 24, we have 21 and 18. And then, in both of these answers, I'm just going to say you don't know. And the reason being, I'm going to animate this slide, is that the cornea is very complex. Cornea curvature, cornea thickness, cornea rigidity, and there's 18 other parameters of the cornea. You can talk about cornea hysteresis, and it goes on. But cornea rigidity is the one that really influences that transcorneal IOP, because that's really what you're doing when you're using Goldman. And when you take one number like central cornea thickness and assume that 500 cornea is mushy, and you assume that 600 is titanium, and that you really had to crank it up, that's a bad assumption. And it's been proven time and time again that there are some 600 corneas that are truly rock hard, but there's some that are mushy. And you could literally go the wrong way in adjusting it. And, I see these cards every so often out there. And back in the day, when the pachymeters come running around, they were adjusting up and down. And I still like talking about it because the majority of the docs think that 500 is truly 24. And the answer is really, you don't know, because what happens if that 500 cornea, instead of being mushy, was rock hard? Maybe their pressure truly is 18. And then you made a decision to treat it because thought it was 24. So you don't know, and you don't know on both of these. So my advice out there is don't adjust IOPs up and down. Kind of use the rule of thumb that which most docs do now, glaucoma docs. It's just a risk factor. If you have an average cornea thickness, say 550, it's not going to really do much to the risk factor. If it's 500, it increases the risk. If it's 600, it decreases the risk. So I always use the analogy, all of us on here have lungs. All of us are at risk for lung cancer. Who's at higher risk? Those who smoke, right? Anyone can get lung cancer. There's people out there that never smoke, got lung cancer, but we do know that smoking has a higher risk of lung cancer. So the key is those from the ocular hypertensive treatment study, those that have thin corneas, those are the ones that are higher risk for the development. But don't adjust IOPs up and down. And then every so often I'll get someone that says, well, I still see my ophthalmologist doing it. It doesn't make it right, guys? So just know the data, know the science, and thin corneas increase risk, thicker corneas decrease risk. It's already an imperfect measurement. Don't make it more imperfect by putting human judgment in there. Joe, any comments on that? That's one of my soapboxes, but do you have any comments that you want to throw in there? I know you're a big glaucoma guy.
I agree entirely. Only thing I want to throw in there in terms of risk is what about that stratified risk in the person who's had LASIK and has been iatrogenically thinned? I think that we just don't know about that, other than that we may not be measuring the pressure correctly. One thing I want to throw out, there have been so many pundits from the stage talking about thin corneas are a surrogate for a thin lamina, and that's just not true. That's actually never been proved. But Greg, I agree. The pressure is the pressure. The pachymetry is pachymetry. Under 500, there's more risk. Over 600, there's less risk. And after that, we really can't see a heck of a lot more.
And sticking to the theme, thanks, Joe. And sticking to the theme of, how to use the OCT and glaucoma and sticking to the anterior segment, you can see right here is just a line measurement going from the sclera onto the, through the angle, for lack of a better term here, or the limbus, and then getting into the anterior chamber, dropping the calipers in here, measuring. You can see Schlemm's canal right here. You can tell right about where you are. Here's trabecular meshwork and Schlemm's canal, getting some of the iris roll here, just kind of figuring out nice 46, 0.54, if you want to get that detailed type of angle for this patient. So a nice wide open angle. I kind of like using OCT at times just because you can do it in the dark. And, when you do gonioscopy, you're using the slit lamp, constricting down that pupil, kind of maybe artificially opening that angle. So there's times whenever I do like to use, OCT in kind of a dark room here to evaluate this angle to see if we're going to be sending it off to maybe for a laser peripheral orthotomy. So you can see here in this patient here, I'm just trying to approximate and putting this down into the angle, the calipers, just trying to figure out, maybe I could have, you kind of use these two rolls. Maybe I could have cut through here. I'm just trying to figure out a good estimation of this angle. And the surgeon that I work with in the practice, he comes in and he does laser peripheral orthotomies. And I'm not saying this is all across, the country, but we've come to the conclusion, hey, Greg, if you do gonioscopy and, you're not seeing many structures in there and you take them into the OCT room and the lights are dim and you can see here the pupil's pretty big and this angle is less than 15, that's a pretty good, amount of risk. You can see how this kind of bending forward here, that this patient's at risk for angle closure, that the surgeon, if I referred it to them, had all this data, they would probably do a laser peripheral orthotomy. So an LPI.
And Greg, I think the one on the left is an excellent example of a plateau iris. And one of the other things qualitatively, not quantitatively, is this shows you what is the relationship between the cornea, the trabecular meshwork, the iris, and the lens. And you can see right here on the right, it's very flat, and there's actually a plateau on the left. And I think that's a really excellent example.
So plateau here
Mm-hmm.
and flat here. And then, if you're ever questioning, here's an angle closure. You can see that the iris is just pushed right up against, no fluid could get through. You can see the angle here and just an angle closure. So, and able to get this off, start your, your angle closure protocol and then get them off to the ophthalmologist to do that LPI, or if you're in the state of Louisiana or Oklahoma, Kentucky, or I think there's a few other states now that have that ability. You can do it yourself as an optometrist.
And actually, Greg, we can go back to that. There's another excellent example right here. If this were coast to coast and you saw the entire chamber, what you see here is clear iris Bombay. And I think that's very impressive. You don't see where the pupil is, but that looks like a clear Bombay, and it's really great example. And one may say, well, I can find this in gonioscopy. I will tell you right now, I've seen some good clinicians get lost in closed angles gonioscopically, where suddenly you start trying to assess reflexes off the back of the cornea and start calling them angle structures because you get lost in the closed angle sometimes.
So that's really all I had for anterior segment and using the anterior segment part of the OCT for glaucoma. We'll jump in and do a little bit of retinal nerve fiber layer and ganglion cell. And just kind of reminder, when you're looking at the ganglion cell complex and the retinal nerve fiber layer, remember if there's a defect superior, temporally, that's the glaucoma prone zones, as you hear Dr. Salka and I talk about. Superior temporal, inferior temporal. That's where we want to look a lot of times on OCTs. Glaucoma is really not nasal or temporal. It's that superior temporal, inferior temporal region. And that could bleed over and arcuate type of defect over to this GCC area, the ganglion cell complex. So when we're looking at that, and sometimes they are side by side, sometimes they're on top of each other, just try to remember this kind of relationship here. And you'll see that as we get later into the webinar of angiography and some of the examples. So just a quick reminder, what is the ganglion cell complex? It's definitely part of the neurosensory retina, but what parts is that? It's the nerve fiber layer, the ganglion cell layer, and the inner plexiform layer. So that's what we're talking about when we talk about the ganglion cell complex. It's really these three layers just being measured by the instrument. And sometimes you have to be careful, but the instruments have gotten really good at segmenting, but still if there's signal errors or maybe some edema in that retina, you might not always get the true ganglion cell complex. You kind of have to look at the segmentation here, and that's what I'm showing you here. And this is great segmentation. It's found the internal limiting membrane, the nerve fiber layer at the top here. It's found the most inner part, or the outer part, I'm sorry, the most outer part of the inner plexiform layer. And you're getting a true measurement of the ganglion cell complex. And there's times whenever I do want to go in and just kind of take a look at it. You don't always have to go by those numbers. And this is a patient with glaucoma. And as you're looking, you can see that this looks pretty normal, but you can see here the nerve fiber layer is thinned on this side over here. You can see that this ganglion cell complex is atrophying away. And this is just a known glaucoma patient that I have, and just showing you that, the segmentation lines, sometimes they can get pretty, down here and getting some thick GCCs, or sometimes it just can't find it. You can go in and adjust it, move it up and down. But the segmentation of this is of both of these examples is pretty good here. But this here is the example of glaucoma loss on this left side as compared to the right side here. So just learn how to dive into your OCT and take a look at those. So here's a polling question number 3 here. We're looking at this ganglion cell complex. We see this GCC is thin. And the question that I have to the audience here, this 82 microns, is this glaucoma? Is these arcuate defects? Is this ganglion cell thinning most likely from glaucoma? Yes, no, or you just don't know. And that's a great answer, because that's why we're here tonight, to all kind of learn.
All right, we're going through.
And just so you know, for those who are, that are here tonight and doing the poll, we're going to go through some slides, and then we're going to revisit this after we go through some slides and just see what happens. So see if the answers change.
I think we're going to end the polling right now. So let's end, and we're going to share the results.
So what do we have here? We have saying, yes, it's glaucoma. No, it's not. And the majority are just not sure. And that's maybe that's why we're here tonight. We're going to revisit this, guys. I'll give you the answer here in just a few slides here. All right. So with that being said, I don't think that we can really jump in until we can do a little mini, is this physiologically normal, or is it truly, disease process? So let's go through and talk about, green, red, yellow, and blue disease. Is it physiologically normal or within the OCT measurement structure? And with that being said, remember that the normative database within these OCTs, ask yourself, how many thousands of people did they put in here to create this normative database? And I kind of set that up for you because it's not thousands, right? It's like 5 or 6, maybe 700 people that are within what they consider to be the normative database. So it's not like they put hundreds of thousands of people and over time the outliers fall out. It's really these normative databases are just comprised of what they consider normal of 600 or 700 people. So one of the pearls I like to teach, or one of the hints, is that if it's disease, and it could be anything, let's just get out of the eye. And I just had this discussion with a patient today while I was in patient care, is that if you think about arthritis in both elbows, it's usually in both elbows, but usually worse in one elbow than the other. People that have hip problems, it's in both hips, but they usually end up getting one hip replacement first, and then maybe years later. So my point is that disease is usually bilateral, but the word I want to point out here is asymmetric. And luckily within glaucoma, that plays true most of the time. Very rarely are you going to have a patient who has glaucoma where their retinal ganglion cells, their neuroretinal rim, their nerve fiber layer is equally dying symmetrically. I'm sure there's a case out there somewhere. But the good news is, in most cases, it's asymmetric. So if the scans are symmetric, then it's most likely not disease. It's most likely physiologically normal, or it's an anatomical variation that's causing that. Looking at scans, and this pretty much applies to, again, most of the OCT units that are out there, is that when you're looking at the ganglion cell complex, on average, it's about 85 to 100 microns. That's what I tell the patient whenever I open it up. I say, I usually cover it up and I say, look, hopefully these numbers are 85 to 100. If they're not, we'll talk about it, because if they're both 85 and 85, and maybe they're flagged, that could be just physiologically normal, just thin for them. They could be 110 and 110, and that could just be physiologically normal for them. And on average, I see them every day being about, in normal patients without glaucoma, about 92 to 95 microns. So what am I talking about? Here's a nice scan. This one has angiography on it down below. It's the macular angiography. But here's what I'm pointing out here. Here's the ganglion cell complex. We talked about the 3 layers that it is made up of. And right here, you can see the average is 98, 96, 2 microns different. 1 micron difference between 89 and 97, 97, 96. In this case, green is good, yellow is caution, red is bad. Now, this is proprietary to OptiView. They call this the focal loss volume. I use this a lot. If it's red or yellow, it really makes me scratch my head about whether they have glaucoma. This is called global loss volume, but I kind of just say it's their general health of their ganglion cells. So this is just something that's healthy. I'm just showing you how symmetric. Within 2 to 1, 0 microns within the eye, 1 micron within the eye, going between the eyes, 2, very symmetric. And you can just go up here, look at the B scans, and come down here and look at the angiographies, but I'm just really focusing on the GCC. So I want to jump into this 46-year-old man that comes in. He has red and yellow disease. He's a very low myope. You can see thyroid, high cholesterol, on medications for these conditions. His pressures are 15. But here is his ganglion cell. And I'm going to put these together. This is the right eye. Here's the left eye. And one of the tips is I just kind of like looking at them with both, because it really gives me a good idea of what's going on. So if you look at their ganglion cell complex, I just said 85 to 100 is normal. But here's a person that's 110, 110, 111, 109, 110, and 111. And you can see 0 microns, 2 microns, and 1 micron different. This one's minus because the left is thicker. This one's positive because the right is thicker. But it's just telling me 0, 2, and 1 micron. Within the eye, 1 micron because it's 111. But very just thicker than average, right? I don't know of any diseases where if the ganglion cell is too thick, you know, they're kind of lucky. They got kind of that bonus that's out there. And that's what I tell them. And you can see here that the focal loss and the global loss looks good. But what this does when you come over here to the retina maps, because the ganglion cell is thicker than average, it's throwing off this norm in the database. Green is in the middle here. Yellow and red would mean thicker than average. Blue means thinner than average. You can see when you come over to the retina, it says, hey, it's thicker, but look how symmetric. 329 to 330, 1 micron different, 64 to 59, 5 microns different, 294 to 292 or 293, 1 or 2 microns different, 2 microns different. Make sure if you get, when you do this, you go inner to inner and outer to outer, or nasal to nasal, or temporal to temporal. And you can see extremely, extremely symmetric. Nothing's going on. There's nothing like an epiretinal membrane causing it to be thicker. When you come up here and look at the maps, it's just thicker than average. Here's another epiretinal membrane with some fluid. And you can see that this is just physiologically normal. There's no disease process going on with this patient. Here's a plano presbyope, a minus 50 presbyope. Pressures are 15 to 18. Now we start getting into this patient. Look, going, oh my gosh, this could be maybe like an arcuate defect. Got some yellow, some arcuate defect. Oh, this could be glaucoma. Got some yellow disease going on here. But let's go down here and take a look. Remember, 85 to 100 83 to 81, 81 to 81, 85 to 82. 2 microns difference, 0, 3, 4, and 1. I don't really scratch my head, or really, if it's a good scan, and let's all assume that they're good scans, that they're, there could be cornea edema, there could be something else going on, cataract maybe causing a signaling, a patient couldn't hold their eye still. But let's all assume that if these are good scans, that this is very symmetric. I don't scratch my head until there's about 10 microns. So this here being thin, looking at this 2, 3, and 2, 0, and 3, 4, and 1, it's saying, hey, doc, don't really scratch your head about glaucoma. It's more a general thinning. And then when you look at the retina thickness numbers, look how symmetric things are. This is just physiologically normal. Patient comes back a year later, even more physiologically normal. 81, 81, 81, 81, 82, 81, 0, 0, 0, saying, hey, doc, it's not really glaucoma. It's just a general thinning. So it's just we had a patient before that had a 110. This one here is 81. That's why I like knowing 85 to 100 is pretty much where I see them all day long. 92 to 95. If they are 81, 81, 82, 81, 81, 81, is it, you think, disease process that's causing that to kind of happen? Most likely not. It's just physiologically thin for this patient and normal. And the same thing is going to happen with this 58-year-old with yellow disease. It's a patient with a very low hyperopia. You can see pressures are 13 and 15. And when we jump and take a look, I can look at them, individually. I like looking at them together because it helps me to get that symmetry side. Again, when you look at this, there's all kinds of yellow and kind of that arcuate defect that could potentially be occurring from glaucomatous thinning in that GCC area. But when you come down and see 82, 81, 82, 81, 81, 81, 1 micron, 0, very symmetric, 1 micron different, 0 microns, saying, hey, doc, don't worry about glaucoma. It's more of a general thinning. And that's what's happening with these. So I like to use symmetry a lot. And here's a 40-year-old man, red, blue, green disease. Now this is a higher myope, which could be, in a sense, axial, stretching the patient out. And so what you can see here is, I don't have them bilateral, so we'll have to go this way, the old-fashioned way. We see in red, 80, 78, 82. That's the right eye. Come over here, look, 80, 78, 81, all within a few microns, saying, hey, doc, don't worry about it. It's not really focal, because that's what glaucoma does. It drives down and creates those focal defects. It's more of a global loss. And you can see that, and that was in 2015. 2 years later, they come back. We do the scans, and you can see the 80s, the 78s, the 83s, still saying not focal. It's more of a global loss. And you can see here, very symmetric. And this thinning here is causing the retina maps to be blue and thin. But again, if you look at these numbers going superior to inferior, they're all within, that 10 microns. So it's that normative database that is not, thousands of people. It's just 600, 700 people, sometimes 500 people, depending on which instrument. And you can see here, 22 months apart, really not having a problem. And really, if you just kind of fold this in half, it almost looks like it would almost be like a perfect ink blot when you just look at the colors and the numbers and just how they line up. So that's one of the pearls I like to teach. Here's just another patient that comes in with diabetes. They do have a little scar right here going on in their retina, but look how thin these are. 77, 77, 77, 77, 77, and this little outlier right here at 78, 0, 1, and 0, 0, 1. Look how symmetric, yellow rim here, little red bullseye, red bullseye. And you can just see how it all translates. When it's symmetric out there, again, I can get burnt one of these days, but most likely if it's symmetric, it's most likely not going to be disease. So that kind of tees it up. So let's look at some glaucoma patients. So again, looking at glaucoma, we're going to look at the retinal nerve fiber layer. And really what you want to look is superior temporal. That's why they have this T-SNP. You kind of look at the superior temporal, the inferior temporal. You want to look in this glaucoma prone zone, superior temporal, inferior temporal, and then superior temporal, inferior temporal. And again, that should translate kind of to this ganglion cell. If you have a defect, it kind of should maybe start arcuate over into this ganglion cell complex. And right here, all I'm just doing is showing you perfectly healthy what it looks like, just to kind of remind us. Again, 0, 1, 0, 4, and 3 microns. This is a patient without glaucoma. So now let's just kind of look at maybe 6 or 7 cases of known glaucoma. Nothing out here trickery, no reason to do that in this type of lecture. And again, going to your patients, let's just say this patient has a high IOP. Here's 110, here's 111, just jumping over here corresponding. Why is this 110 and this is 74? Here it's 124, here it is 111. So you might argue that this might be the one that's healthy. There could be a little bit of loss inferior, but there's certainly loss superior temporal here. And you can see it right here on the T-SNP, right in that superior temporal area. You can see how this is down and being pushed down, and again, pushed down here. I would say that there's an inferior loss here, maybe some superior loss there, but definitely more. Luckily, glaucoma is asymmetric. So now when we go and we look at the ganglion cell complex, let's look. Superior is 93. Here's 78. Look, there's 15. Remember that rule of thumb I like to use? I start scratching my head anywhere around 9 or 10, say 10 microns. This 15 microns right here really is starting to make me scratch my head. You can see right here why it's starting to show up here. Nothing over here. Really cool about this instrument here with this focal loss volume. Look how it's flagging this, saying, hey, doc, you better really scratch your head. It's more of a focal loss because that's what happens in glaucoma as opposed to more of a general loss. So the glaucoma is worse in the left eye of this patient. You can see how this superior temporal is kind of arcuating over here to this superior part of this GCC. Glaucoma is worse in the left eye and the right eye based on this OCT analysis. Same thing over here, just another patient, different patient, just going to show you a bunch. Just jumping into the GCC, 12 microns, 18 microns, 5 microns. Again, here's that 10 micron difference that kind of makes me scratch my head. Definitely worse. You can see the focal loss here is flagging it, saying, hey, doc, it's pretty focal. It's not really a global loss. Here's 82, here's 87, and 85. Coming up here and taking a look, you could see this glaucoma prone zone up in here. The superior temporal versus inferior temporal, both are damaged, worse superior than inferior. And you can see what's happening over here, superior temporal versus inferior. Again, another kind of this arcuating over, catching the superior ganglion cell and inferior ganglion cell. And you can see what's happening here with the T-SNP maps, definitely worse in the left eye than the right eye. Glaucoma worse left than right. And another patient here, I was starting to think that maybe in my patient population, all my patients would be left. But again, let's jump down to here. The ganglion cell complex is 6, 8, and 4. The focal loss is saying, it's more focal, doc. Scratch your head, maybe look a little bit closer, even though it's not meeting that, say, 10 criteria. This 8 is. But check this out. Look how it's being flagged as green. And then these ones here are being flagged as yellow, and this one here is being red. And this is the one with the most asymmetry being green. So be careful with the greens, be careful with the yellows, be careful with the reds. But if you come up here and study the nerve fiber layer, again, a little bit thinner than you expect, but still in green, but being flagged down here at 84. And over here, it's 112. And you can see this one over here is 103. So the inferior temporal of both of these right through here, inferior temporal. You can see how this mountain is being pushed down. Still not too bad over here. You can just see how this is being pushed down. Again, the asymmetry is what I just want to keep driving home as we do these. And then another example, starting with the ganglion cell complex, known glaucoma patient, 11, 4, and 18. And that's why when you look at these and you're scratching your head, ocular hypertensives, funny looking nerves, run a scan on them. And if it's symmetric, it's most likely, physiologic. what you got going on. Obviously, you want to follow them over time, see if asymmetry does develop. But you can see here the glaucoma is worse, at least OCT wise, in the right optic or right ganglion cell complex versus the left. And you can see that's what's causing this 11, 4, and 18. Inferior, definitely the worst. You can see here starting to get a little asymmetry, even though this is being flagged as green, right? We could say green disease. It's being flagged, and this is yellow and green, but this is still all green up here, even though there's some thinning going on, especially over here in this right eye. Why isn't it being picked up? It's just not outside that normative database yet. And you come up here and you look at the glaucoma prone zone, inferior temporal versus superior temporal. Look at this. Look how symmetric this is. 110 versus 110. Coming down here, now flagged as red, 92 versus 81 right here. So definitely worse in the left eye. I'm sorry, definitely worse in the right eye than the left eye. And then you can come up here and study the retinal ganglions, retinal nerve fibrillary numbers. So then there's progression analysis, and I put these in here to kind of just show what these gray bars are. These are the confidence intervals. And it's usually a little bit easier to get a little bit tighter with the ganglion cell complex. And that's really because when they do this measurement, and you can, if you're doing them yourself, or if you have a technician, when they do the ganglion cell complex, they say to the patient, just look straight ahead. You should see a green or red dot. Just look straight ahead, because that's the macula. But in order to get to the optic nerve, they got to eccentrically fixate. Hey, look over there to the side. And they're kind of looking over there to the side, looking at that red or green light. Maybe their eye's moving a little bit. So I usually will judge that if the confidence interval is a little bit tighter in the ganglion cell than over here with the retinal nerve fibrillary, I'd say it's a pretty good scan over here. There's probably not anything in these scans. It's really maybe throwing off some of these measurements when you're doing the progression analysis. This one here would concern me because, the patient was able, or the instrument saying, hey, the retinal nerve fibrillary, while the patient's eccentrically fixating, maybe one of these, ganglion cell scans. But most of the time you're going to see that the ganglion cell is a little bit tighter, like in this left eye, than the right eye. And the confidence interval saying this blue line, in a sense, could be as high as here or as low as here when it's doing the trend analysis. And that's what, when you're doing the trend analysis on these, or progression analysis with these units. And not sure why my mouse keeps doing that. Sorry, guys. So let's go back. That's the one I just showed you. And like here, right here, this would be, this is some pretty wide confidence intervals. I might want to study these, try and figure out which one is causing it over time and maybe get rid of it. Even though the trend analysis looks pretty flat, it's not good crashing down quickly. This is a pretty wide confidence interval. And even this one's trending upwards. So, maybe the technician over time is getting better. Maybe this is a bad scan, as we're seeing here with these black areas here. So, but again, ganglion cells a little bit easier to scan because they're looking at it with their macula, eccentrically fixating for their optic nerve. And this is always nice. You can see, glaucoma suspect. We're following him over time. Good symmetry going on here. What we call a good T-SNP. Temporal, superior, nasal, inferior, getting that T-SNP right here, temporal, superior, nasal, inferior, temporal, kind of just getting that up, down appearance because that nerve fiber layer is piling up superior and inferiorly, specifically superior temporally, inferior temporally. So this following this patient over time and seeing that they're not progressing with this strong family history. So polling question number 4 here, Joe.
All right.
We have, which OCT now is most likely due to glaucoma? Is it A? Is it B? Or they both have glaucoma, neither have glaucoma, or you just don't know? So everything that we just talked about, looking at these two OCTs, Is A glaucoma, B glaucoma, both glaucoma, neither, or you don't know?
All right, this will probably take a little bit longer. We got to think about it, Tad.
So Joe, I got a message here that was to me, direct message as a question. It says, what criterion did the OCT companies use to determine which 500 sample patients they used for the database? I'm really not sure what criterion they use. I can certainly reach out to these companies. I work with them closely since I lecture on OCT, but do you have any idea what that answer would be?
Well, the first criteria is what would be most representative of the population. And once they got that answer, whatever that answer was, then they tried to extend out to include the next most common part of the population that would have glaucoma, and then the next, including people of African descent, Caucasian descent, Asian descent. But getting approval and getting through the FDA for these normative databases has been very challenging. There very well could come a time when normative databases are actually going to be probably removed. Okay, we're very good. I'm going to end the polling right here, and I'm going to share the results.
Yeah, so this is pretty cool because remember I said I wasn't going to share the results of that first poll because this is that same exact scan. So we can see here, we're asking which one is most likely due to glaucoma. And I understand you don't have patient history and optic nerves and visual fields and so on and so forth, but just trying to use OCT as maybe a mono factor in evaluating. Yes, I would agree A. When you look at this, there's asymmetry between the ganglion cell complex, that inferior temporal, inferior temporal, superior temporal seems to be intact, worse in the right eye than the left eye. I agree. Left, the A is the glaucoma. Jumping over here to B, very symmetric. 82, 81, 82, 81. We saw this one earlier. That one had earlier 38%, 40% of the people felt that this was glaucoma. So that's why it's kind of fun to do these and kind of teach some concepts and some interpreting pearls. And we can see here that it's saying focal. Don't worry about glaucoma too much. It's more of a general loss. So, and then, a couple of people said neither. And again, a few people said, I don't know. So let's kind of jump in here to the next generation, in a sense, glaucoma analysis with OCT and OCT angiography. And, ask yourself, when was the last time that this is a glaucoma suspect, or this is a ocular hypertensive, and man, I wish I could do a fluorescein angiography on it. I've never said that. And OCT angiography, I really can't practice now at the level that I feel is a high level without the other side angiography. And the reason being, we always say the crime must fit the punishment, right? If it's an infection, use an anti-infective. It's an inflammatory, use an anti-inflammatory. So like if we're going to look for plaquenil toxicity, I certainly wouldn't want to use angiography because it's more of a buildup of the plaquenil and the RPE, and then the buildup creates, toxicity to that parafoveal retina in atrophy. So it's really not a capillary disease, but diabetes is a capillary disease. Wet macular degeneration is capillary. Moving into, other conditions, you want to use maybe the B scan OCT again, like in that plaquenil toxicity, or maybe looking at epiretinal membranes or vitreomacular traction, really not a capillary disease. So the crime must fit the punishment. If I want to evaluate macular degeneration or diabetes, I want to have OCT as maybe my early detector rather than the B scan, and vice versa for things that could affect the structural part of the retina. Here, it's kind of been a nice little mix. I'm not really going to defend one or the other. I'm using GCC, as you can see, like in this case here, I'm using, retinal nerve fiber layer. I'm using GCC in the glaucoma case, but you're going to see I use the radial peripapillary capillaries and what's happening in that macular density when I follow these glaucoma patients. And it's been a nice little another tool. We have the visual field that provides that function measurement. GCC in nerve fiber layer is a structure measurement, measuring the capillary density and the radial peripapillary capillary density is another structural measurement. And it's been nice in following some of these patients that I have. So let's just kind of hop in here. So remember the nerve fiber layer, we're looking around the optic nerve. So we're able to measure the radial peripapillary capillaries, the RPCs, you'll hear it referred to from time to time. And in the macula, right, that's where the ganglion cell complex can become thin. We're looking at the capillary density within that, in that sense, that inner retina, that superficial retina. And this is what normal looks like. And I'm going to show you some cases here of what glaucoma looks like. So here's a normal case, and then here's a patient with moderate glaucoma. And notice how you're starting to get this kind of wedge defect of someone that has maybe an inferior temporal, right? It's in that part of that nerve. But this is that same patient, and see how this kind of just kind of arcuates around. Oops, that's my fault. Kind of arcuates around. And I like knowing this because I can see when the macula is potentially going to be involved. And maybe I want to be a little bit more aggressive if it's their macula being involved, but meaning in their treatment. But you can see here that this is kind of looping around. And here's more of a more advanced glaucoma patient. I'll have some better examples. I like using this one here as moderate. This is being normal and seeing how those, in this case, the radial peripapillary capillaries are being atrophied, and just the those inner superficial and deep capillaries are being atrophied away from the glaucomatous disease. Going back and just putting that back into correlation, that's that structure test of ganglion cell. Just kind of see how this is kind of arcuating around right here. Here's that optic nerve, and this is kind of a superior. This here is not this case here, but kind of showing, remember, thin here should create maybe something eventually thin superiorly kind of arcuating around. Here you can just kind of see that nice little wedge defect and how it just kind of arcuates around right around this way. So, how does OCT change the way you see glaucoma? Right? So there's early changes in the retina and optic disc. It adds new information to the diagnosis, and they do have progression analysis detection. So again, it's just been a nice little add-on. OCTA has been great again in macular degeneration, great in diabetes, and it's been good for glaucoma. It really hasn't said, oh man, I really don't need GCC and nerve fiber layer anymore. It just kind of gives me another look and confidence to make sure that if I'm following someone and I'm not treating them with a high pressure, that another structural measurement is not being affected. So I just want to kind of show you some normal scans here. Here's a review of a normal 25-year-old man. He was an extern of mine, and we're scanning around the optic nerve, and there's 3 scans. There's a choroidal phase. This is what they're calling the radial peripapillary capillary phase, in a sense, down here between the internal limiting membrane and nerve fiber layer. We're getting out to the kind of the vitreous part of the scan. But what we want to do is come down here and we want to just look at how robust, and this is in a percentage of vessel density of radial peripapillary capillaries. It gives us a hemifield and a quadrant. And it goes back, those same pearls, those same tips that I gave earlier about symmetry. And I look at these all day long, and these are usually about 50. I'm going to tell you right now that when you're doing the angiographies, you need to have a good scan. And how these work, this angiography works, is that within a second, 1/1000, there are 70,000 scans that go off. Going back to the what was it? The Stratus, the Zeiss Stratus, when that was considered time domain, there was about, I think, 16,000 scans per second. Then the spectral domains came out, and then they got themselves up to about 35,000 scans per second. With that, you got higher resolution. You got more data coming in, 35,000 scans per second. How they went from spectral domain, still within spectral domain, to get OCT angiography is you need an instrument to be able to scan at about 70,000 scans per second. And if the patient's holding their eye still enough, then really the only thing that's moving is the blood. And through all the programming, if they subtract out what's not moving, then you can see what's happening with the capillaries. And that's how that all works. So picking up on those red blood cells, white blood cells, and plasma and proteins, everything that's in blood and moving, it's able to, through the micron network, able to pick up the flow pattern and subtract it all out. But obviously, if the patient's moving their eye, it's hard to be able to, it all becomes a blur. So a good scan image will get you about 50. Then you look at the quadrants. Again, superior and inferior should be thicker than nasal and temporal. This over here is a nerve fiber layer. So just kind of showing you what healthy looks like on a nerve scan. This is a retina scan looking. I can tell you over here, this is the nasal side. It's always thicker on the nasal side than the temporal side. And then you can see here that these are on a 25-year-old, nice and healthy, kind of those high 50s for the percentage of capillaries. So here's a partner in my practice, very healthy, not on any meds, takes good care of himself, eats well, so on and so forth. And again, you can see age really doesn't play a difference. Look how nice and healthy. Go back one, you can see here's the 25-year-old. Here's the 60-year-old again. You know, age really doesn't cause an issue. You can see nice, healthy radial, peripapillary capillaries, 52, 53, thicker, superior and inferior. Well, a little thicker temporally here. Coming over here, you can see in the macula, this is the nasal side. This is the temporal side. You can see, or I'm sorry, this is the temporal side. Sorry, let me say that again. 44 thinner is temporally, thicker nasal. You can kind of see where the optic nerve would be right here. So this is, again, 60-year-old. Again, the capillary outer retina. We're kind of in glaucoma looking here, macular degeneration looking here, back to diabetes looking here. You can montage these images. And this is what OCT used to look like when I first got it. One thing I like about the OptiView unit is you can get these measurements. I don't think there's any other unit out there, and I'll take that with a grain of salt. I am going to SECO this week, and I am going to chat with Zeiss and Heidelberg and all the different companies in their exhibit hall. At least COVID and during COVID, I've been trying to keep my finger on the pulse. The nice thing about this is that this is called angioanalytics. It's able to measure. And whenever I used to look at scans like this, it was a little bit tough, but it's kind of cool. They montage them, and you can see right here, it's taking the optic nerve and the retina, and you can see it's kind of just seaming it together so you can see what happens. And this gets pretty cool sometimes in the glaucoma scans, and I'll show you a couple of those today. So will you be showing any Stratus OCT printouts? I will not be showing any Stratus. I don't have a Stratus in my office. At some point, Joe and I can merge. I think Joe, when he was at Nova, had Stratus. I'm not sure what you have in your current practice, Joe.
No, we use a lot of OptiView. There is some Heidelberg Spectralis. And while at the university, I exclusively used Cirrus. I'm not sure they meant Stratus or Cirrus.
Yeah, Stratus is, I believe, the older unit, right?
The original time domain.
Time domain.
And
yep.
Cirrus is the next generation from
spectral domain. Yep. So again, you can do some fun things with this. I'm just showing you this here so I can show you what it looks like when we get to some of the glaucoma cases and how it can be used in glaucoma. And that was the 60-year-old montage. And this is, again, the 60-year-old montage. Now, I did receive a couple emails. One doesn't move me, but 3 does move me, I guess. And someone said, well, you talk a little bit about some visual fields tonight and merging it in with some of the OCT interpretation. And I said, okay, I guess I can. So here's some bonus visual field, even though it's an OCT. So let's just kind of pause, let our minds kind of set free of OCT. Let's talk about visual fields, and then I'll get back to the OCT angiography. So, this is a 50-year-old woman. This is a very old case, as you'll see here, because it's a 50-year-old woman was told to come to her office because she had ocular hypertension. She needed follow-up. She moved to the area. She was diagnosed 18 months ago on Travatan, not Travatan Z, but Travatan. That's how old this case is. 2015, everything's unremarkable. Slight hyperemia, pressures are 13 and 14. So here are her optic nerves. And when you look at these optic nerves, I think you would agree that they're larger cup to disc ratio, but I think she falls into the isn't rule, where inferior is thicker than superior in nasal and temporal. Here, inferior, superior, maybe thinner here, and it all fits within the isn't rule. So, again, ocular hypertension. So I got her records and reviewed her records, and her IOP was anywhere from 16 to 19. Seeing this doc in the office anywhere from 8 o'clock in the morning. Sometimes she was there at 8. Sometimes she was there at 5:25 at night, getting pressures read, and anywhere from 17 to 20, kind of tight. 16 to 19, anywhere from morning to afternoon. Pachymetry readings were thin there at 505 and 505. Visual field results showed this nasal defect on this 24-2. This is the left eye, so just kind of like I am looking at the screen, nose being here in the center. That's how I like to do it. So nasals here, nasals here. So we have a nasal defect. We can tell this is a 24-2 because it only goes 24 degrees here, 24 here, 24 here, but glaucoma is nasal. So 30 degrees nasal, 30 degrees nasal, 24, 24, 24. So we got ourselves a little nasal defect. So I'm not sure nasal defect, and it wouldn't be ocular hypertension. So when we take a look, it's a kind of a mild to moderate defect, very localized. And you can see right here, it's these points right here creating this nasal defect. These ones right here. So, people wanted questions or wanted some things on what does mean deviation and pattern standard deviation. So what does it mean, mean deviation? Well, mean deviation just tells you how deep the defect is. So I just one day I counted, there's 54 points, and just this real quick analysis here. If all 54 points were decreased by 1 decibel, 54 times 1 is 54, divided by 54 is 1 decibel. But if half of them were decreased by 2, but the other half were normal, still 27 times 2 is 54. All of these scenarios here are going to give us a mean deviation of 1. So if I had a quarter of them that were decreased by 4, that 13.5 times 4 is still 54. All those scenarios, again, equals mean deviation of 1. But what I'm trying to show what pattern standard deviation does is, because when the whole field is involved, your pattern standard deviation is low. But when it starts to become more localized, the pattern standard deviation starts to go up. So that's why mean deviation tells you how deep the defect is. And then pattern standard deviation tells you how localized it is. And pattern standard deviation goes up in glaucoma. So when we look at this patient, you're going to say, well, this could be glaucoma because it's a mild to moderate defect, but it's very localized. Well, it's very localized because this rim defect right here, because glaucoma usually doesn't go 27, 27, 29, 24, brightest light, brightest light, brightest light, brightest light being off. It's usually a rim or the trial lens that's blocking it. So this mild to moderate defect, it's very localized, is very localized because there's a trial lens blocking the source of the light and the patient can't see it. So, why is this patient being treated? We repeated the visual field, we stopped the Travatan, and at that point I had a GDX. How about that? Way before even Stratus. GDX. So we stopped the Travatan. I used to always tease the Alcon docs like, hey, look, stop the medication and look what happens. The defect goes away and the mean deviation gets better. Like, hey, don't say that. But what you're seeing here now is the rim is not blocking the patient. And now you're getting the true reading. So now you have a very mild defect that's kind of scattered throughout the whole visual field. So that's what mean deviation and pattern standard deviation does. We ran the GDX at that time, and you can see the beautiful symmetry that's occurring in this back then still T-SNP on this patient. So, this patient, when I chatted with her, she went and she was talking about, hey, yeah, my pressures were 19, but my cornea was 505. And so they raised my pressure up and said my ocular hypertension was really high risk ocular hypertension. And so that's how she ended up on treatment. Now, remember, I was at PCO, or I remember being at PCO whenever they were enrolling. Dick Bennett he always says he's the only optometrist that was in the study that is correct as a lead investigator. I was at the optometry school in 1995, 96 when they were enrolling patients in there. I was able to enroll a few patients. And if we go way back to the beginning of this whole case presentation, this patient would not have been able to even be entered into the ocular hypertensive treatment study because what does she lack? Ocular hypertension. She had a thin cornea. When that came out, we all used that thin cornea to raise the IOPs and then started treating because she had a large cup to disc ratio, which was a risk factor, had a nasal defect, thin corneas. And this was a patient that was backdoored into the ocular hypertensive treatment study and treated. And we were able to get her off her treatment because she didn't really need to be on it. So really cool case. I thought I would talk about visual fields this way, kind of throwing in a case to satisfy those who are out there. Hopefully that was good enough to help you out. So a question that I have, and we can launch this, Joe. Well, final thought on the visual field. What is the mean deviation on a 24-2 threshold visual field of a blind eye? I don't have that on here, but what is the mean deviation on a 24- visual field of someone that has a blind eye? Is it +5? Is it 0, -5 decibels, 12 decibels, 32, or 50? Someone that has a blind eye, what's the mean deviation? Is it +5, 0, -5, 12, 32, or 50? Remember, this is a blind eye.
NLP, right?
NLP.
Or NLP -2, actually. It's worse than NLP.
There you go. NLP, it could be NLP -2.
All right. We're getting there toward the end, so I'm going to end the polling for the sake of time. I think we're slowing down.
So 0 is the majority answer here. Now remember, 0 would be what would be expected as being a normal visual field. On a blind eye, those who answered 32 is the most acceptable answer, and I'll show you here why in a second. So I actually did this the one day. I walked in. I was out there doing visual field interpretation. I walked in on a Monday after flying on a plane, being in a lecture, kind of pondering this stuff. And I walked in and I said to my technician, I said, "Hey, Sarah, do me a favor. Walk into the room, plug into the visual field, plug in age 30 or 35, whatever's listed here. Let the visual field run as if they're a blind eye. They would never hit it." And she kind of looked at me and said, "Hey, doc, you really have a bad weekend? What's going on?" I said, no, I just need to know this. So here it is, age, say 30 or 35. Let the visual field run. You can see these are all zeros. And you can see the mean deviation is -34. And it's very diffuse, right? It's very diffuse because the whole eye is blind where we're measuring. This is what we call parametric blindness. I did it right here on a 65-year-old because I wanted to see if it would change the algorithm of the visual field, and it did. It changed it to -32. So really, whenever I'm doing, and this is kind of going back now to structure versus function, getting kind of fold back in the OCT, because you really just can't use OCT. You got to use photos, neuroretinal rim analysis, looking at the nerve fiber layer, 3D, undilated, photos, gonioscopy, folding everything back in. But when I'm doing visual field testing, I don't want my patient to get to minus 32 if I'm treating them. So, I turned on, let it run minus 32. Now, a lot of people ask how I set a target IOP. When we were at the Optometric Glaucoma Society meeting, kind of sat around one time. It was kind of loosely debated that 0 to 5 would be a mild defect. 5 to 10 is a moderate defect. Anything above a 10 is a severe defect. Because if minus 32 is a blind eye, is minus 16 half blind? And the answer is no. Severe blind in that eye would be a minus 10. So if there's 0 to 5, I like to set about a 30% reduction, and that's on the worst eye. If it's 5 to 10 on that mean deviation, about a 40% reduction. And then if it's greater than 10, that's severe glaucoma. If it's from glaucoma, then it's going to be a 50% reduction. And then, you can check your APD skills. If someone's a 5 in one eye and 10 in the other, the eye that has a minus 10 should have an APD. So if you want to check your APD skills. Now, let's go back and fold some of this in. I hope that was satisfactory. Again, I had a few people email me about that, and so I decided to throw it in because I felt in this lecture we'd have some time. Here's a 68-year-old woman with glaucoma. All right, nothing tricky here. This isn't cases. We're all about learning tonight. This isn't like case presentations where we're trying to fool and do red herrings. She wants a second opinion on her glaucoma. She had cataract surgery with an eye stent in September 25th, 2017. She's currently using dorzolamide 2% twice a day, Lumigan once a day in the left eye. She came to our practice. Our surgeon decided to do Cohook dual blade on July 24th, 2018. She had a little bit better outcome on that eye because without any drop, she's 12. With an eye stent and dorzolamide and Lumigan, she's got a 16. I still keep, even though I'm electronic in the office, I still keep a paper chart and a keep chart. I like being able to look at the visual field, not electronically. I know I can scan them in and find them. I like to be able to flip, see the visual field, see the OCT. I have a more professional sheet. I used to just handwrite it. DFE, visual field OCT, gonio photos, the dates that I did them, and just make sure that I'm tracking. She had an eye stent. Make some notes down here, Cohook dual blade. You can see here I did her pachymetry readings. This one here said minimum 569, 579. Those were the thinnest areas. This is one I showed you a little bit earlier. Using pachymetry, OCT anterior segment to get her pachymetry readings. Here are her just traditional nerve fiber layer and GCC. Inferior temporal, again, kind of bleeding over here to this inferior ganglion cell loss. Superior temporal, worse inferiorly than superior. Looking at the glaucoma, you can see it's worse in the left eye than the right eye. Let's go up here and take a look at the ganglion cell. We have a 9 difference, a 5 difference, and a 13 difference. Again, highlighting the asymmetry part of this being worse in the left eye than the right eye. You can see even the optic nerve head analysis is flagging it as yellow. Jumping up here to the retinal nerve fiber layer, look at the asymmetry. 17 microns, 20 microns, and 14 microns. Here you can see that not so bad superior temporally, but the asymmetry that's occurring here superior temporally. So again, worse, using all those kind of pearls that we talked about. You can see what's happening down here with the T-SNP and interpreting this kind of structural test. Jumping to her visual field, how is she looking? Again, it's worse in the left eye. She's got this inferior defect. You're getting nice adherence here and correlation with the superior arcuate defect. She has a -6. This is a moderate defect in this eye. She's 79%. This should be 100%. She's down to 79% here. She's 82% here. -1. She's not close to -32, right? That's why this is important. She's not -32. She's -6. She's still closer to 5 than 10. So just a moderate defect here. So moderate glaucoma in a sense in the left eye, mild glaucoma in the right eye using the visual field. You can see the nasal defects that are occurring. Now, how does that correlate structure versus function? Now going back to angiography, giving me another way to follow this patient, and take a look in this right eye, this nice little wedge defect, the nerve fiber layer dropout right here. And look what you can pick up. We can see this radial peripapillary capillary dropout that's occurring right here. When we come over and look at the hemifield, it's not too obvious because it's such a small defect, 49 and 48, here 50 and 46. But when we come over here and take a look at this side, look how wide this one is and look at the dropout. Remember, it was worse in the left eye. 41, 38, look right here, 49, 48. Now look at the asymmetry difference between the eyes, 50 to 39, 36 to 46. And you can see here a nice little wedge defect and the capillary dropout that's occurring in this patient. So we have a way, another structural measurement, structured GCC, nerve fiber layer, function, going back to another structural measurement, but now of capillary density of the optic nerve in this case. And now we can jump. Oh, this is kind of cool. Sorry. This is the ONFOS images. Take a look here. This is pretty cool. You can see the defect. You can see the defect here. When I'm looking at the ONFOS, looking at the capillary dropout, looking at the capillary dropout, and showing how it's looking here as it goes through the kind of the retinal scans. And then that translates over into the macula, right? Remember that GCC was thin, and look how this kind of translates right over, and you can see the dropout in the capillary density. And you can just kind of see how it follows that kind of perfect arcuate, but does not cross that horizontal raphe right there. And then coming over this way, you can see again coming across, not really crossing the horizontal raphe, but now the superior side is becoming involved. You can see it coming right around here. You can see it coming around here. And measuring these capillaries will help me to be able, as another way of doing progression analysis for this patient. And here you can see the montage image. Look how this is pretty cool. You can see it just leaving that optic nerve. You can just follow this. This is more just kind of cool and educational for the patient. There's really no analytics going on here with this patient. And then this would be the left eye here. And this is the eye that's a little bit worse, right? So remember how wide it was, more obvious, and kind of just see. And I like this because it kind of reminds us what that scan around the optic nerve is looking at, picking up this area, and how this kind of arcuates around to pick up that ganglion cell kind of measurement. And here they are side by side. You can see a little bit less in this right eye, a little bit worse in this left eye. This is just a big PVD right here blocking this. There's no signal right here because there's a PVD, but worse in the left eye than the right eye. So just another case here. We have a 74-year-old man. Glaucoma is worse in the left eye than the right eye, on Lumigan and Comigan. Again, you can see this is maybe a little bit more established patient, how I make sure I'm getting my DFEs, my visual fields, OCTs, photos, PACs, OCT-A. You can see I started adding that. And then I like to know what their baseline or Tmax, and then I set a target pressure. So I still keep a kind of a dashboard of what I'm doing for these patients and making sure I'm getting tests that I want to do and reevaluating and making sure we have these patients well cared for. So we're saying that it's worse in the left eye than the right. So let's take a look here, worse in the left eye. You can see here we have an inferior defect. It's a mild defect. It's so mild, it's only 1.30. It's very localized. And we can come over here and it hardly has any defect, right? Or it's a plus. It's not even a minus. It's 0.53. So clean visual field in this right eye, a little mild defect inferior of the left eye here. And we can see over time, we're seeing what's happening with the progression analysis. Maybe not a defect here early, but it's not that deep of a defect, but you can see what has happened over a course of 8 years. And we can see here, we got maybe a little bit uphill trend, which sometimes happens when you take the stress off of those retinal ganglion cells. You can get a little bit of recovery. Remember, it's worse in his left eye. So let's take a look at the ganglion cell complex. 6 difference, 13 and 2. It's worse superiorly in the ganglion cell complex of the left eye. So you can see that's what this is picking up here. Again, there's that 10 number that I like to use kind of as a rough asymmetry. Again, it's saying right here, it's more glaucoma related. You can see what's happening here. Superior temporal kind of bleeding over, creating this defect right here, the superior temporal nerve fiber layer in the ganglion cell complex. Inferior here, superior here, but look, really not affecting the ganglion cell yet. We do have nerve fiber layer loss, nerve fiber layer loss, nerve fiber layer, not really here, but there's enough again in this left eye, and that's the one that's causing that visual field defect. And you can see what's happening here. 2 microns different, 13 microns different, and 8 microns different. Doing pretty good over time, checking his progression analysis. And then, hey, let's do some OCT on him and see what happens. Here's his nerve fiber layer scan. You can see what's happening to the radial peripapillary capillaries. Little thinner inferior here, 34, 43. Over here, the left eye that's worse, you can see 32 and 38, 27 for sure in this quadrant. You can see how thin the nerve fiber layer is, and 42. And the nice thing is now I've measured him yearly, and I got to update these slides, and then we can do a progression analysis with these patients, just like we can with the OCT. Now that was the radial peripapillary capillaries, which would kind of correlate with what's happening with the nerve fiber layer. And remember the macula scan, which is clean in his eye, in the right eye, and thin in superiorly in the left eye. So when we jump over to his scan, you can see what's happening in this left eye. You can see it's a little thin here. You can see he's thinning out, not so bad inferior, definitely superior. And you can see what's happening over here in the right eye, maybe a little thinner than we would expect, but remember it's flagging it here as being green. So it's nice, again, being able to use these, all the tools within the toolbox when treating glaucoma. And here they are just montaged, being able, again, to kind of, this is more to kind of show off what the instruments can do. This is more information, maybe patient education. Not so great because there's really no numbers on here to be able to measure with these patients. I thought this was kind of cute. They do read their electronic health record. I was reading my patient chart online, which was emailed me right after today's visit. I noticed that my weight was recorded at 344 pounds. Please, that's incorrect because I weigh 133 and I've been holding steady between 132 and 134. So I just thought that was kind of cute to say, okay, guys, they do read their electronic health records. And some people are sensitive about certain things. All right, this is a fun one. And he just came in today. And if I didn't have the handout out, I was going to rush home and update this case. I've been following this gentleman since 2014. His pressures are running 35 as of today. And he has ocular hypertension. He's got pigment dispersion. His IOPs, were Tmax at 26 at one point, hopped up to 30 to 32 back in 2018. And as of today, his pressures were 35. So he's a physical therapist, good friend. He has high pressures. He gets risks, benefits, treatments. He understands glaucoma to an extent that, we've talked about it lots of times, how it's structurally being damaged, retinal ganglion cells, nerve fiber layer, function is visual fields. And he doesn't want to be treated until there's, in a sense, the earliest of damage, because we have the ability to be able to, with the technology we have. So we keep running his visual fields. His visual fields continue to be 100%. So his visual fields are perfectly clean, and they're still clean as of 2021. Now let's go back and take a look at this. Back in the day, he was running high pressures. And would you say, ooh, look at this GCC, guys. This could be glaucoma. Now, his T-snits look good in that superior temporal, inferior temporal. Let's go and take a look at some of this. Look, it's even flagging it as red. Now remember, he's a higher myope. So look at the average. 0 difference in microns, 1 different, 2 different. The test is even saying, doc, it's really not glaucoma, it's just loss. Remember, he's running a high pressure. This is physiological right here. Look how symmetric this is. You come up here, look how symmetric his nerve fiber layer is, 0, 1, and 0. Everything is super symmetric. Look at these T-snits over time, right on top of each other, right over left, right over left. Glaucoma is usually asymmetric. This here might cause people heartburn, but use some of the pearls and you can see that this is more physiologically thinning, not glaucoma thinning. So remember, he's running a high pressure. So finally, we got this instrument. I can measure it, and he comes in. And I'm like, oh my gosh, what am I going to find? And I found everything is perfectly normal. He's got great radial peripapillary capillaries, superior, inferior, great numbers. Same thing here, great numbers. How's he looking in the macula? He's looking good. Now this eye might look a little thin, but this is back in the day before I realized that the scores need to be a little bit higher. This was a 7 and this was an 8. And I measured him today and his scans, his OCT, we got qualities of 9s. He looks wonderful. So he's got great macula density. He still has great radial peri. He's walking around with pressures of 35 for about the last 7 years. And we're looking at him montaged here and looking at the montage here. So, how does OCT change, the way we see glaucoma? It shows early changes in, the retina and optic nerve. It adds information to the diagnosis, and it adds progression. Again, going back, we touched about visual fields, and visual fields measure function. We also talk about structure with OCT, nerve fiber layer, ganglion cell, and now we have the ability to use another structural measurement using the measurement of the radial peripapillary capillaries and the macula density of those patients. So it's been really fun in the practice to be able to have this technology and to be able to use it. And you go back again, you've heard me say it, but I'll say it again. It's definitely been great in diabetes, great in macular degeneration, good plus to great for glaucoma. It really hasn't given me that, oh, look, we can catch things a lot earlier by this, like we can in diabetes and like we can in macular degeneration. It's been a nice little add-on to determining if it's progressing, stable, how my management and treatment of glaucoma is going. So poll 6, let's throw this one out there, Joe. And then are there any comments that or questions that have rolled in?
Let me pull up our poll. Hold on. And here is launched polling. And our chat room is clear.
Okay. So I feel more comfortable in interpreting an OCT, an OCTA for the diagnosis and management and treatment of glaucoma. after listening to that last hour and 40 minutes.
And we're cruising on through.
Joe, I know you do a lot of glaucoma lecturing. We probably have a minute or two to kind of fill some
Mhm.
dead space here. Do you have any comments or anything that's kind of sitting on your head that you can add to the OCT lecture?
Well, actually, a couple of comments have come in quickly. What are the last patients? I think it was a spell check. PAX, not peaches, but PAX. What was the last patient's PAX?
I don't know. Did I have them in here? They're not really, they're probably average if I don't have them in here.
Well, I'm gonna end the polling and share the results, and the vast majority certainly agree that they're much more comfortable with OCT and OCT angiography in glaucoma. So going back, a couple other questions. You don't find that.
Let's see, right here, I have them in my spreadsheet. So I didn't have it over here on the typed part, but if you go to my dashboard, that's where I thought it would be. 589, 589.
And that's why we have a dashboard.
So
Is OCTA covered with glaucoma suspicion diagnosis or ocular hypertension diagnosis? This is, I think, a very good pertinent question that you can answer here.
So OCT angiography does not have a CPT code. So there's a couple of ways that you can approach it. I always say there's, Christian guilt, Jewish guilt, but what supersedes it all is optometric guilt. You can, patient comes in with an OCT, what I call B scan, the traditional OCT. And if you want to feel that you can, you want to kind of couple it in there and kind of bill it through that way. But you can come up with a charge. We have a charge in our office, and we just created a 9999 code, and we just charge, what we feel is appropriate for this. I believe in our practice, it's $35 or $40. I do sit as the third-party chair for POA, and people always get a little concerned when you start dropping numbers. There's, over 100 people on this webinar tonight, and I'm not telling anyone how to bill. I'm telling you what we bill, and we don't give this service away. This technology is important, especially in diabetes and macular degeneration, and now in glaucoma. So there's no CPT code, long drawn out story for OCTA. We created a code and we can charge for it.
What are your thoughts on using ERG in glaucoma diagnosis, Greg? That was one of our chat questions.
Yeah, and I'm gonna maybe defer to you, Joe, on this one. For decades, the companies have reached out for me to consider putting this into practice. ERGs and all the electrodiagnostics, and every time I've gone to a show, I've got close to maybe pulling the trigger, bringing it in. And I don't want to speak positive or negative about it in any way, just because I have zero experience. I like to speak from clinical ways and how I do things in practice, and that's how I teach. So I don't really have any experience to say that it would help me or not help me. I'm sure that there's a positive aspect to it, but I don't really have any way to, in the diagnosis of a glaucoma, I'm sure it would be helpful.
There's a fair amount of research in support of it. It is another tool in the armamentarium, much like OCT. I think that if one were to employ this in their diagnostic armamentarium, it would help elevate their practice to really an elite level, much like OCT and OCT-A. At some point, we could get overwhelmed by the amount of information. That's why I still think that perimetry and disc analysis are still very, very important. Now, a question that came through to me: does the Zeiss product have the same capability to quantify the capillary density as demonstrated from the OptiView? The answer is I don't know if they have upgraded to that or they have added that just yet. I do know Zeiss has a very good OCT angiography program and device. I don't know about the analytics at this point. I am no longer using it in my new practice. But I would like to get Zeiss back, the Cirrus back in my new practice. And one thing that I want to throw in here, because I know we didn't have time to talk about, and this is one that I do. But interesting, some studies came out looking at what is the most sensitive parameter on the Zeiss OCT for identifying neurofibrillary defects in glaucoma. And this is in comparison to what was the gold standard of red-free photography. And interestingly, when they looked at the clock hours, the T-SNIT, the quadrant hours, they found that the thickness map was actually the most sensitive. So actually looking at the picture on Zeiss was actually very, very helpful. So thank you all. That was OCT and OCT Angiography in glaucoma. We have a few other webinars coming up. So if you want to handle the housekeeping there, Greg.
Yep. I'm just going to pause for a second, Joe, and thank everyone for being here again. Thank you.